I think we'll start. Please, this is very informal. If you have any questions, please raise your hands as we go through the slides, and I'm happy to answer. So, my name is Rajaraman. I'm an epilepsy doctor at UCLA, and we're going to talk about difficult to treat epilepsies, what's next, and what are your options. So I'm a pediatric epileptologist. I did pediatric neurology. I did a fellowship for epilepsy, but I'm trained for pediatric epilepsy and adult epilepsy, and I kind of treat all ages. I'm the director of the Tuberous Sclerosis Center of Excellence. TSC, or tuberous sclerosis, is a rare genetic epilepsy. It happens about 1 in 8,000 live births. Pretty common for a genetic epilepsy. And I'm also director of the CDKL5 deficiency disorder. It's another rare genetic epilepsy that I'm very interested in. We have over 10 clinical trials at where I'm a primary investigator for, so there's lots of new trials and different things you can try if things aren't helping right now, and we'll get into that. So, what is a seizure? And just kind of the main point. Has anybody ever been kind of explained what a seizure kind of is it is a sudden surge of abnormal electrical activity in your brain. So your brain has normal electricity, normal brain waves, and a seizure is when that electricity becomes very abnormal. It kind of comes together and causes a seizure. And epilepsy is recurrent or unprovoked seizures. So you're having multiple seizures and you have epilepsy. So it's very common. Epilepsy is more than autism, Parkinson's, and multiple sclerosis all combined. There's 65 million people in the world have epilepsy, and about 3.4 million in the US will have epilepsy. So very, very common. This is just a picture of us at the Rose Bowl for the Epilepsy Foundation Walk. I think it's really important if someone has epilepsy, to have a community, have support. This is from the Epilepsy Foundation, Greater Los Angeles. You're here at Disney Day. So there's a lot of organizations and community support. So what causes epilepsy? So we're going to kind of go over the causes and how you can treat them, right? So what can cause epilepsy? One is if you have a structural abnormality. So we always recommend getting imaging of the brain to see if there's any kind of abnormal structure or something you were born with or some kind of injury that can explain. So imaging, getting MRI is very important. Next are genetic causes. So we're finding new genes every day, so I highly recommend, if you haven't had genetic testing, that's a good next step. So whether it is a chromosomal microarray, which is one type of genetic testing, whether it is an epilepsy panel, which is the most common epilepsy genes, so about 300 genes that we know of can cause epilepsy. There are commercial labs that actually do the testing for you and accept insurance, that your doctor has to just order the epilepsy panel. And then also there is whole exome sequencing, which is testing all or almost all of your genes, looking for a genetic cause. And if unknown, it's likely genetic, but we just haven't discovered the gene yet. And 6 out of 10 people with epilepsy have an unknown cause. So I highly recommend that at least we do the MRI, do the genetic testing, and you can kind of see what is the possibilities for causing it. Any questions about what could cause the epilepsy? Or about the kind of testing that can be done? So what causes epilepsy? So you can have birth injuries for babies and children, sometimes deprived of oxygen in the womb. Others are genetics, so whether it's autism, like I mentioned, tuberous sclerosis is a genetic disorder. You can have a traumatic brain injury, you can have a stroke, infections, tumors, and all this is kind of based on history and putting the imaging together. So we recommend doing history and physical, doing the EEG, obtaining imaging, and then genetic testing. So whether it's like I mentioned, the chromosomal microarray, the gene panel, or whole exome sequencing. So then how do we treat epilepsy? So here is a list of medications, I think going up to 2018. There's even more medications since then. There's over 20 plus medications, and if you see, there's a large influx of new generation medications. So if you have tried medications in the past and they haven't worked for you or they've had side effects, highly recommend looking at newer medications. A lot of them have less side effects and can sometimes be more effective. So if you've tried medications in the past and it's not helping, I would talk to your epilepsy doctor and say, hey, what are the new medications? What are the options? What can work better and what would have less side effects? And you kind of know, based on what you did before, what might be causing side effects or not. If medications do not work, and this is where we kind of talk about intractable epilepsy. So if you failed at least 2 seizure medications, you're considered refractory and intractable. And when I say you failed 2 meds, that just means you tried 2 meds, you got to very good doses, and it just didn't stop your seizures. So if you're at that point, it's worth doing a pre-surgical evaluation, which means you get admitted to a level 4 epilepsy center, and most of the big epilepsy institutions are level 4 centers, and we do something called a pre-surgical evaluation, which means is your child amenable, or is your child or adult, at any age, are you able to have epilepsy surgery safely with minimal risks, and could that kind of stop your seizures? Just because you're getting evaluated for epilepsy surgery doesn't mean you're signed up for epilepsy surgery. It doesn't mean you have to do it. It's just good information for your doctor to know, for you to know, hey, I've had seizures, the meds didn't stop them, can I do surgery, and is it possible that would stop my seizures? Okay, I'll get back to that. And then also clinical trials. So there are a lot of drugs that have not been approved yet by the FDA, and they could be specifically for the epilepsy syndrome or the genetic epilepsy or the thing that's causing your epilepsy. So I highly recommend looking at NIH.gov or just Googling clinical trials with the diagnosis, and there could be new research trials, new drug trials specifically for your epilepsy syndrome. Any questions about this? Yeah, please.
Just out of curiosity, that one slide over the different drugs.
Yeah.
What determines the generations? Like the rate of the ranking of the generation?
It's usually, there's a period of time where there was not as many clinical trials going on, or the medications were on the market, and then it took a while before a new wave of medications came, or new discoveries, or new mechanisms of actions, because some of the older seizure meds work certain ways, and then new drugs work different ways, so just kind of based on discoveries. So the generation is just kind of based on the timing in which the medications got approved. So yeah, clinical trials, you have access to new drugs with possibly less side effects. They're often being designed specifically for your genetic cause or whatever is causing your epilepsy. There's very close monitoring, so you talk to your doctors all the time. Some of the cons is that initially you could be placed on the placebo, which means that there's a period of time where you don't get any drug, you're just on your regular seizure drugs because you need one group on drugs and one without, but at the end everyone gets the drug. There could be unknown side effects, and of like any drug, you might not see any benefit. So we're discussing epilepsy surgery. So this is one patient who had temporal lobe seizures, and the seizures came from the right side of the brain. And then after surgery, this hole right here, you can cut out that part if your seizures come from here, and then the seizures stop. But in order to see if you are available or you're a patient that can have epilepsy surgery, you need to do the workup or the evaluation. So this is the epilepsy surgery evaluation at UCLA. It could be very different at other centers, and they might have certain tests they do versus not do. So you do video EEG, you need to capture the seizures on EEG to see what they look like. You have to do an MRI scan, which looks at the structures. We, at UCLA, we do a PET scan, which looks at your brain's metabolism, because some parts of the brain might not work well as others, and they'll be low in metabolism. And you say, okay, that part of the brain's not working that well. It could be coming from that area. These are additional specialized tests, a MEG scan and a SPEC scan. And those are two tests that can also give you more information from where your seizures come from. And then we do functional MRI and neuropsych testing to see what the pluses and minuses with where your brain is functioning and what are your strengths and weaknesses and where you think the seizure is coming from, if you can cut that part out. And then we do a meeting with epilepsy doctors, radiologists, surgeons, psychologists, and we talk about your case, and then we say, hey, is yes or no, is surgery a good option? Has everyone in the room heard about epilepsy surgery before or been advised about it? Yeah, okay. I think having information about epilepsy surgery and just seeing if it's a candidate or if that's an option for you is at least worth getting evaluated. If epilepsy surgery is not an option, so then we have other therapies. So we talked about medications, we talked about surgery, we talked about clinical trials. So diet therapy. So there are one major diet, which is the ketogenic diet, which is a very high fat, very low carbs, adequate protein diet. It's been shown to be effective with epilepsy. It's a pretty strict diet. You have to weigh your food. You have to do close monitoring with your keto team. But I think that's definitely a good option. It's been shown to help with epilepsy. Now, if keto diet is not a possibility for your child or for you just because it might be too strict, there's something called the modified Atkins diet. I know there's been talks here about the modified Atkins and keto. Modified Atkins is a less strict diet, but it's also been shown to be effective. And the other one's called a low glycemic index diet, which is another type of diet for epilepsy. This is the Charlie Foundation. If you go to charliefoundation.org, it's a really good website about the keto diet and different kind of things you can learn about it. So here is kind of the breakdowns of classic keto is about 90% fat, modified Atkins about 65%, and then low glycemic is about 60%. So it becomes less and less strict as you go down based on the diets. So ketogenic diet is a good option outside of medication. We often don't try it early enough. You need constant supervision with dietitian and neurologist. A lot of people do the keto diet or different kind of diets, trying to lose weight or for energy or for the gym, but it's a little bit different when you do it for epilepsy. It's very strict and you have to do blood monitoring and working with the team is the best way to do that. And then breaking the diet is like kind of skipping a medication. So we really recommend families to be invested, kind of being part of the diet. And if you feel like the diet's not working for you, you can always try to stop it. But we usually recommend try the diet for at least 3 months. Give it a good try because it doesn't work overnight. Any questions about the diet? One other option, so we talked about medications, surgery, the diets, so we also have devices. Now there's kind of 3 major devices. One is the vagal nerve stimulator, which is in this picture. Then you have the RNS or responsive neurostim device, and then the deep brain stimulator also. These are 3 devices which are approved to treat epilepsy in the US. Some of them, this one, the VNS, the device doesn't go in the brain, it goes on the chest, and there's a lead that goes to the vagus nerve, which goes up to your brain. So it sends a constant signal trying to stop the seizures. The responsive neurostim device is actually putting a device here, and then you're putting EEG leads in the brain, and actually records seizure activity. And then when the device sees a seizure, it sends a signal to try to stop the seizure. So it's a little more invasive, but it actually has EEG recordings to try to stop the seizures and record in live time. And the deep brain stimulator, it's been around for a while. It's been used for Parkinson's. But again, it's putting a device in the brain to stimulate and try to stop the seizures. So those are my slides. Just to show you one more time, in case, just to reflect real quick. So we went over the causes, whether structural, genetic, the different kinds of causes, our workup usually. Then we talked about the medications and the newer medications that are available. We talked about clinical trials for the specific causes. Then we have epilepsy surgery, how to evaluate for epilepsy surgery. And then we have the diet therapy, and then the different devices. And these are some of the major treatment options we have now for epilepsy. We have plenty of time, so I'm happy to answer any questions. My name's Raj, I work at UCLA, I'm peds epilepsy, so any questions, peds or adult epilepsy, I'm here to help. Yes, please.
Do the RNS or the DBS devices work for absence seizures?
It can. Yes, it can. Any other questions? Yes, please.
So how, for the devices, would it also work for Dravet syndrome individuals? Will they have different types of seizures?
Dravet syndrome?
Yes.
Yeah, so I think it could be an option too, the different devices, kind of based on what seizures you have and what you've tried before in the past. Dravet syndrome is one of the genetic epilepsies where they do have a lot of clinical trials going on right now. And there are medications specifically approved for Dravet, so like Epidiolex and other kind of medications, they've been approved too. So that's one of the genetic epilepsies where there's different options. So I think I would look at what kind of newer medications, the clinical trials and devices, it definitely could be an option. Yes, please.
Okay, I have a couple of questions.
Sure.
Would improvement, if you saw improvement after the VNS got placed, does that change the possibility of being able to see the location or source of the seizures before to be evaluated for epilepsy surgery? Say you couldn't see it before, does that have any effect? Have you seen that?
You know, it's a good question. So you can still be evaluated for epilepsy surgery, if that's what you're asking. You can with the VNS device. You just have to make sure your center is okay doing the MRI with the device placed in, which should be fine. Radiology just has to know that the device is there.
If you weren't though, or have you seen patients who have, once you were unable to see, let's say my son has fires.
Yeah.
So they're not able to see the location of the seizures when they probably last evaluated him maybe 6-7 years ago. So, but he's had improvement with the VNS, with the ketogenic diet. Have you seen in any of your patients where once you were unable to see where they were coming from, and now you're able to, either with better medication or better control, because he does have better control, it's still refractory,
Sure.
or maybe newer technology from 7 years ago,
Yeah.
would it be beneficial to get evaluated again, I guess is what I'm asking.
Yeah, I think so, just because sometimes seizures settle down and he might just have one type. It might be coming from one part of the brain. It's worth doing the EEG just to see what your options are. Now, sometimes there's things called palliative surgeries, and that the surgeon might not say, you have a really high percentage of seizure freedom, but this could definitely reduce your seizures or dramatically reduce it to a reasonable percentage. So even if the chance of seizure freedom is low, there's still epilepsy surgeries that could help. So, and sometimes, in the beginning, like especially what you're describing, the seizures can be kind of everywhere, It might settle down later. Or now the seizures could be generalized, but you wouldn't really know until you kind of do the EEG and see what's happening. Sure. Did you have another question you said?
Oh, no.
Oh, okay. Any others? Okay. Well, I'll be up here for a little bit, so if you want to ask individually, I'll be here. I'm Raj. Thank you, everyone. Appreciate it.